So welcome everyone to meeting number 30 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic. I'd like to welcome our witnesses. In this panel, as an individual, we have Ms. Winnie Shen, Associate Professor, Organization Studies, Schulich School of Business. We have, with the Association des Gastroenterologues de Québec, Dr. Mélanie Bélanger, President. With the Coalition for Canada Basic Income, we have Dr. Cordell Neudorf, Professor and Medical Health Officer. And with Moms Stop the Harm, we have Ms. Leslie Bain, Co-founder and Director. With that, we will start. We will invite the witnesses to present their statement, starting with Ms. Shen. Ms. Shen, please go ahead. 6 minutes, please.
Thank you, Mr. Chair. Honorable members of the committee, thank you for the opportunity to speak with you today. My name is Winnie Shen. I am an Associate Professor of Organization Studies at the Schulich School of Business at York University and current Chair of the Canadian Society for Industrial Organizational Psychology. As an organizational psychologist who conducts research on issues of gender and diversity in the workplace, I have been asked to address the disproportionate impact the COVID-19 pandemic has had on women's workforce participation and the importance of addressing these unequal impacts on the road to equitable economic recovery. There are two interwoven strands that have contributed to why women have left the workforce more compared to men as a result of the pandemic. First, in contrast to prior recessions, such as the Great Recession of 2008, the industries most harmed by the pandemic through job loss are those where women tend to be more strongly represented, those involving people and significant interpersonal components. This includes the hospitality and retail sectors, contributing to greater impacts on young women and women of color. Additionally, the pandemic has put more strain on small and medium-sized businesses relative to large organizations. Female-led businesses tend to be smaller on average than male-led businesses and may be in more financially precarious positions due to greater difficulty in accessing capital. Further, women dominate many segments of the healthcare workforce on the front lines of the pandemic. Significant burnout and ensuing turnover have resulted from our protracted battle against this virus. Second, the pandemic has increased care responsibilities, which have mostly fallen to women. The unavailability or unreliability of childcare and school during the pandemic tends to be borne mostly by women, leading to reduced work hours and decisions to leave the workforce. The impacts on single parents, most of whom are single mothers, are particularly stark. Similarly, we know that elder care responsibilities also tend to disproportionately fall upon women, and those have been heightened during the pandemic as well, given the vulnerability of the older population to the virus. As we look ahead towards recovery, we need to ensure that women are not left behind and to carefully consider if there may be unintended consequences of policies on women. We cannot simply assume that the jobs lost in female-dominated industries during the pandemic will come back quickly or at all. Companies that are managing costs by understaffing during the pandemic may choose to continue to do so given ongoing uncertainties. Additionally, to build a more resilient and fair economy, we should consider how to make gender representation across industries more balanced so that future economic downturns are experienced more equally across different segments of the population and that the most vulnerable are better protected. For example, increasing the pay associated with people-oriented work so that more men consider these jobs, or incentivizing women to pursue opportunities in traditionally male-dominated industries where there is great need for entrance, such as in the skilled trades. The pandemic has also highlighted the precarity of our progress towards gender parity in the workforce and the related financial security it provides to women and families. Without intervention, the pandemic could have a significant impact on women's careers for decades. We know that employment gaps are often viewed unfavorably by employers, which can make future job seeking more difficult and can have long-term impacts on future earnings. This may particularly be the case if employers interpret these gaps as a signal that women are not committed to their careers and invest less in their career development over the long term as a consequence. Finally, the pandemic reinforces that people's, particularly women's, ability to participate in the workforce are dependent on the resources available to support their non-work responsibilities, such as caring for those in their families. Thank you for this chance to share my views.
Thank you. We go now to the Association des
The Association of Gastroenterologists of Quebec.
Mélanie Bélanger, 6 minutes, s'il vous plaît.
6 minutes, please, Doctor. Good morning. I am the president of the Association of Gastroenterologists of Quebec. I represent 273 members. We are the physicians who specialize in the investigation and treatment of digestive diseases and the only physicians who are fully trained to perform digestive endoscopies, including those required for the prevention of colon cancer. Endoscopy is a way of exploring the inside of a body cavity. We perform colonoscopy to study the colon, and gastroscopy to study the stomach. Thanks to recent technological advances in endoscopy, we are able to perform interventions, take samples, and remove lesions through natural channels, thus avoiding the need for conventional surgery. These are short procedures, often less than 1 hour, without general anesthesia, requiring no hospitalization, and with no convalescence period. The estimated cost of a colonoscopy in Quebec is less than $1,000. Colonoscopy has a crucial role in the prevention of colon cancer. Colon cancer is the third most common cancer in Canada and the second most deadly. According to the Canadian Cancer Society, 27,000 Canadians are afflicted with it every year and 9,700 die from it annually. Colon cancer is a preventable cancer, which is different from the concept of early detection, as it is the case with breast and prostate cancer. Colon cancer screening, by performing a colonoscopy on a portion of these patients, allows for precancerous lesions to be removed and for patients to not develop cancer at all, thus preventing surgery, chemotherapy, and mortality. It has been scientifically proven that a colon cancer prevention program decreases the occurrence, severity, and mortality of this very frequent cancer, affecting people as early as their 50s, sometimes earlier, men and women almost equally. Quebec is the only province that does not yet have an official colorectal cancer screening program. Patients must still take action themselves and ask for a prescription to have a FIT test. This test is indicated for all Canadians over the age of 50. It is a stool sample that looks for the presence of microscopic blood, invisible to the naked eye. If detected, the patient is referred for a colonoscopy. 5% of FIT tests are positive, and therefore as many colonoscopies are necessary. The recommended time frame for colonoscopies is up to 8 weeks to avoid progression of lesions while waiting. In this population of patients who have a positive FIT test, 35% will have polyps, i.e. precancerous lesions, and removing them will avoid cancer. 6 to 8% will already have cancer without any symptoms. Approximately 20,000 colonoscopies per month were performed before the pandemic. Since March 2020, there has been a significant reduction in colonoscopy access, with a negative impact on the number of polyps and cancers detected. With the sharp decline in endoscopies during the first wave, followed by a recovery that is still incomplete to this day, only 73% of colonoscopies were performed in Quebec in 2020 compared to 2019. Thus, 63,000 fewer colonoscopies were performed during the pandemic, resulting in more than 107,000 pending colonoscopies in Quebec, 63% of which are overdue. In order to slow the increase in colon cancer and mortality, significant catch-up work will be required. At present, gastroenterologists do not have the human resources or the access to equipment that is necessary to do this catch-up work. Here are our proposed solutions. First, rapidly set up new endoscopy rooms. Second, secure dedicated budgetary envelopes and give a specific status to endoscopy units, such as the emergency room and the operating room, to allow for the stabilization of specialized nursing staff who contribute to productivity and to make sure that that funding goes specifically to endoscopy units. Third, invest reasonable amounts in client follow-up and quality control mechanisms. In closing, I hope I have demonstrated that thousands of voiceless, asymptomatic Canadians are the sick people of tomorrow, and that the urgent should not make us forget the important. Thank you for your attention.
Merci, Doctor. We go now to Coalition for Canada Basic Income. Dr. Cordell Neudorf, please go ahead. 6 minutes, please.
Thank you, Mr. Chair and committee members. I am both a public health physician and an academic who does research into the causes of health inequities and the impact of what programs and services have on reducing these inequities and improving health and well-being. I'm speaking to you today in my capacity as a member of Coalition Canada Basic Income, which is a coalition of basic income and anti-poverty groups from across Canada that formed near the beginning of the COVID-19 pandemic in response to the early signs and predictions of the inequitable impacts this event would have on the Canadians that are living in poverty. Our members have worked for many years with community service organizations, non-government organizations, concerned citizens, people with lived experience, as well as academics and other experts to advance the case for an evidence-informed approach to improving income support programs in this country. It has been well documented by our Chief Public Health Officer, Dr. Teresa Tam, in her October 2020 report called From Risk to Resilience, an Equity Approach to COVID-19. There has been a disproportionate impact on subpopulations, those who face racism, stigma, or discrimination in many forms due to both the disease itself as well as the interventions that we've had to use to bring it under control. This report outlines several high-impact areas of action as a way forward as we move out of the pandemic, learning from what it has exposed. And the first and foundational area mentioned is that of economic security and employment conditions. In the first few months of 2020, groups that worked with populations living in poverty were faced with impossible choices. They were being asked to close or adapt services to keep clients safe from COVID, knowing that this then risked disrupting this precarious balance of supports that these clients depended on. They've joined our coalition as they've seen the limitations of our current systems of supports and services firsthand. Income supports that were put in place to help Canadians who found themselves out of work during the pandemic response helped a lot of individuals and families who were one paycheck away from homelessness and poverty, and showed that government can be nimble in mobilizing resources to help those in need. However, some people who did not qualify and were already living in poverty may have received bad advice or applied for this funding only to find that they were then subsequently cut off from existing income supports or being asked to pay this money back. Or in other cases, the amounts they'd been receiving through existing programs was substantially less than the cost of living, and it made the CERB an attractive option for survival. Others faced eviction once temporary bans were lifted on evicting people during the crisis, or saw their lives thrown back into crisis as precarious supports and services were cut back due to COVID safety concerns. The pandemic and our responses in controlling it essentially have exposed gaps in our complex system of the programs and services that we have for those living in poverty. But multiple studies in Canada and elsewhere have also shown that those living in poverty have had more cases of COVID at a higher rate, higher hospitalization rates, and higher deaths than other Canadians. Fortunately, there have been many studies already done to show that this doesn't have to be the case. Previous experiments with guaranteed annual income in Canada and elsewhere have shown that participants experience better health, both physical and mental, and have utilized fewer health and social services. And the vast majority have used this more secure base of income to stabilize their current circumstances and better plan for their future. Our existing old age security and guaranteed income supplement programs have moved Canada from having one of the highest levels of poverty for older adults among OECD countries to one of the lowest, while the rate of food insecurity among this age group has dropped 50%. Similarly, the child benefit has raised over 334,000 Canadian children above the poverty line, and UNICEF views this as a model of an effective basic income program for that subgroup. So as we make progress in decreasing poverty in this country through these types of programs, we need to address the other subpopulations who are still living in poverty. Our current programs and services often have complex eligibility criteria and regressive qualification requirements, such as the need to liquidate current assets or claw back any income earned while on assistance, that collectively serve to keep many families in poverty. This has drastic consequences for their health and well-being, leading to yet more costs to deal with the after effects of the health and social costs of poverty through downstream funding and even more services. This pandemic has shown us that we need a stronger base to rebuild on to make us more resilient to face future crises. By adopting a guaranteed annual income, families impacted by job loss during a future pandemic or major change in the economy would know they were secure while they waited for their jobs to return, or they would have flexibility to retrain for whatever jobs emerged in the new economy. In addition, we'd have a simplified system with less administrative costs, with more of the investment going directly to those in need, simultaneously reducing indirect costs of poverty and reducing the complexity and efficiency of our current system. So in closing, the costs of a guaranteed annual income are not insignificant, but the costs of dealing with the after effects and downstream impacts, as well as our complex current system, are almost at large, perhaps even larger, with less impact. Many studies have shown that for the most complex cases, the costs of health, social service, and justice systems' current response to the effects of poverty and homelessness are enormous and often leave people in the same or a worse condition in the end, with little hope for the future. We can learn from the successes and limitations of our pandemic response and build back better. Basic income has the potential to enable all Canadians to live healthier lives by reducing the negative health impacts associated with living in poverty. It is for this reason that many health and social service organizations, including public health, endorse developing a basic income for Canadians. Thank you.
Thank you, Doctor. We go now to Mums Stop the Harm. Ms. Leslie McBain, co-founder and director. Please go ahead, Ms. McBain. 6 minutes. Ms. McBain, you're muted.
Sorry about that. I am the co-founder of a nonprofit national organization called Moms Stop the Harm. Two other moms, Lorna Thomas and Petra Schultz, and I lost our beautiful sons to drug harms in 2013-2014. In the next year, we decided to act. By early 2016, we had an organization of 18 people. Today, our members number well over 2,000 families across Canada. Our aim was and still is to advocate for evidence-based drug policies that support rather than punish people who use drugs. We do not want any other family to experience the deep and lifelong pain of losing a child, especially to a preventable cause. We continue to advocate for humane drug policies, and we now also have a network of trained peer-led support groups that support families in grief and also support families struggling to keep their loved ones with addiction alive. With the help of provincial and federal grants, we have expanded the groups across Canada. In the past 12 months, our membership has soared. It has expanded to dads, friends, siblings, religious leaders, First Nations people. This is a result of the exponential rise in the number of toxic drug deaths and survived overdoses in Canada during the pandemic and the attendant rise in drug use. How has COVID impacted these families and their communities? The impact has been and remains profound. Given the conditions that the pandemic has imposed on all of us and the community of drug users and their families, we find that families have increasing levels of stress, fear, and anxiety if their loved ones with problematic drug use are still alive. More often now, families receive desperate phone calls as services disappear through COVID restrictions, or the one phone call no parent ever wants to receive. Treatment and recovery services are as ridiculously expensive as they have ever been. There are longer wait lists, and people are dying while they wait. Many families who are fighting for the lives of their loved ones have already faced COVID-related economic hardship. This turns into desperation. Mental health services are inundated and unable to cope with the rise in need. One of our members, a single mom with 2 teenagers at home and a son with mental health issues and addiction, has lost her job as a retail manager due to COVID cutbacks. When she had a dependable wage, rent was affordable, childcare within reach, and she was able to connect with her addicted son who chooses to live on the streets. She often gave him money or another phone or bought him clothes or another backpack. In the reduction of services to help him, she is now his sole protector. Now she does not have enough money to help him much, and she now has a serious gastrointestinal disease caused by the stress. Her doctor says, reduce your stress and take these pills. The grief within families and communities that have lost loved ones to toxic drug deaths is a tear in the fabric of Canadian society. Since COVID appeared, the grief felt by families who lose a child to drug deaths is exacerbated by not being able to gather for funerals, wakes, or other traditions. People do not visit or bring casseroles. The surge of the psychological impact of solitary grief rages side by side with COVID fears. People who have substance use disorder, which in normal times is challenging, stigmatized, and a dangerous disorder to have in this country, have been cautioned to isolate during COVID, just like the rest of us. What this means to people who are addicted is extreme vulnerability. The previous message given for many years, which is never use alone, always have a buddy nearby, is almost null. People who use drugs take COVID warnings just as seriously as the rest of us. Using alone during COVID is more dangerous than it ever has been because of increased toxicity of drug supply. If a person overdoses, they will likely die alone or suffer permanent brain injury in the absence of help. COVID has interrupted the normal flow of illicit drugs into Canada. Drugs that traditionally come into Canada across borders, although toxic, were somewhat comprehensible. People who are addicted had some idea of the strength and the inherent dangers. They were still dying, they were still ending up in the ERs, but not in the numbers that we see today. Local illicit drug manufacturers, not willing to ignore a very lucrative market suddenly appearing, have hastily started producing powerful substances, throwing in highly toxic drugs in amounts that kill. Toxic drug deaths have increased 120% since 2019. During COVID, like the rest of us, people with substance use disorder are disconnected from their communities, their families, and their living situations. Shelters have closed, services have closed or become very limited, safe consumption services have closed or have severely cut their hours. This often causes increased drug use as connections have disappeared. And connection means everything to people who use drugs, as well as to the rest of us. I am not an academic. I am not a scientist. I am a bereaved mother who has heard 2,000 stories. I know the wash of grief over this country, and I see the physical and psychological toll on our members before and now, especially during COVID. If the federal government, in partnership with provinces, could act on the evidence and implement a safe supply of drugs to people who need them, decriminalize possession of personal amounts of illicit substances, and make investments in a system of care that makes rapid access to treatment and recovery and mental health services accessible to everyone, the effects of COVID, the effects of the current drug scene, the deaths and the desperation of families would definitely be mitigated. Thank you very much.
Thank you, Ms. McBain. We'll start our questioning now. We'll start with Mr. Barlow. Mr. Barlow, please go ahead, 6 minutes.
Thank you very much, Mr. Chair, and thanks for our witnesses for being here today. And Ms. McBain, I'll start with you, if that's okay. Certainly appreciate you sharing your personal story, and sometimes it is beneficial when we have not academics, but people who have lived experience. And I know, unfortunately, too many of us have had friends, relatives who we've lost as a result of the opioid crisis, which has been exacerbated as a result of COVID-19 and the pandemic. I wanted to ask, certainly we've seen the numbers as a result of lockdowns and restrictions and the use of substances, and opioid deaths and suicides have increased dramatically over the last year. And my province of Alberta, we had the second highest number of suicides in the country over the last 6 months. Would it help to have a one-stop single 988 suicide hotline manned by mental health experts? It's something we don't have in Canada right now. The current system we have is different in every province. Many times when people call, they get an answering machine or a recorded message. What kind of a difference would it make as what could be a quick and easy step is a 988 suicide hotline manned by mental health experts? What kind of difference would that make?
I think anything helps. Everything helps. If it were a hotline that could address suicide as well as other mental health issues, and even including, I should say, drug use and addiction, we need something. Yes, that's a great idea. It can't hurt. But at the same time, what we need is across the board. We need connection through a phone line or through a phone app, where people who are using drugs are able to connect with somebody who's listening. And I don't know if you've heard of the app, but Lifeguard is called, and where they have to respond within a certain few seconds, or emergency services are called. So anything that helps keep people alive during this pandemic is invaluable. Suicides are up, and we need whatever supports are available. So the answer is yes, of course.
Thanks, Ms. McBain. Sure, and my province of Alberta, I know is piloting that app program, as I'm sure other provinces are doing as well. So that's a good first step. You talked about the inability to gather, and the isolation has become even more difficult. And I think your question or your comment was extreme vulnerability. Is the lack of vaccines and to get the vaccines out and get people vaccinated to get life back to normal, is that, I know that's not an issue regarding opioid use, but is that a huge component of this? Is just trying to get some sort of pathway to getting back to normal where people are able to gather again?
Oh, absolutely. I think we're all waiting for things to become safer. And when people lose a loved one to any cause, we have traditions, and we have, as I say, we have rituals and things that are really important to our mental health in losing someone that we love. Families who lose a loved one to drug harms are already dealing with the stigma and the isolation due to just that, to problematic drug use. We still have that. So without the supports in place that we would usually normally have, their lives become very dark and desperate a lot of the time, especially, if they can't have people coming over to hug them or to, just to sit with them. Vaccinations are incredibly important. And I think we all know this is the only way we're ever going to get back to any semblance of normal. And especially for the people who are so vulnerable to grief, that this will make a big difference.
Thanks, Ms. McBain. Sorry, I just have a limited amount of time, so I don't mean to cut you off. Ms. Shen, I just wanted to move to you if I could. You touched on some issues which I know many of us are hearing about, but certainly in some Zoom calls and webinars we're having with our chambers of commerce and trying to see the impact on small businesses. I think one of the biggest messages I'm hearing now is from women who are small business owners who are now having to take on the stress and anxiety of worrying about their business, worrying about their employees, worrying about their families, and also the families of their employees, taking on all of that responsibility. And, I can't imagine the stress that they're going through trying to run their business, working from home, and also trying to balance their children's education, and many times who are at home. What would be some recommendations, Ms. Shin, on some programs or steps that we could implement, or recommendations we could put forward to try and to address this, as I'm assuming the ramifications of this will be long-term?
Yeah, I think that is very true in terms of managing multiple competing demands all at once. And I think that one recommendation would need to be, I know the federal government has put in place a lot of attempts to help small businesses, but I think part of it is a lot of that is just going towards keeping businesses afloat. It's not really enough to kind of make any, and it's also very limited in time, right? So it's hard to plan ahead. And so even if today is taken care of, tomorrow may not be, and you're worried about not only yourself and your family, but also, as you mentioned, the health and well-being of all the people who you are employing, right? And I think that more consistent, longer-term planning is needed for people who are running businesses, especially given the ongoing uncertainty to deal with the pandemic. I think we need to find ways to ensure continuity of care for people. We know that trying to manage, as I'm in Ontario, we're in kind of our third lockdown. The sudden needing to school and care for children at home makes managing work and family responsibilities very difficult at the same time. So we need to find, I think, new ways to make sure that we can find care opportunities for people. And I know that these are difficult issues, but I think that's the reality that we're faced with, that if we don't deal with these issues, that we will start to see people who can no longer sustain their business or who are forced to opt out of the workforce entirely.
Thanks, Mr. Chair. Thank you, Mr. Chair.
Thank you, Mr. Perlow. We go now to Mr. Kellaway. Mr. Kellaway, please go ahead.
Thank you, Mr. Chair, and hello to my colleagues. And I really want to thank the witnesses for their testimony today. So I'm going to focus on Dr. Neudorf. And Dr. Neudorf, as you know, I've been an advocate for basic income in my riding and in the Atlantic region. Our government, we implemented a number of support measures for Canadians throughout the pandemic, most notably the CERB. And I think at one time, there was about 7.5 million people on CERB. So for me, in essence, the CERB acted as a kind of a basic income for those who needed it the most. So I'm interested in a couple of things. What do you think we can learn from CERB, number one? And can we use that model to begin to create a national framework for a basic income?
Yes, well, certainly, I think one of the main things that CERB showed us was that it is possible for us to orchestrate a broad-based income support quickly and nimbly from the federal level. Something that has been debated for some time, and have very quickly, even without pre-planning, getting that kind of funding into the hands of Canadians who needed it very, very quickly. I think what worked well for those that were targeted specifically by CERB could work at least as well for those who perhaps did not qualify. We know that there are many others who found themselves impacted by the pandemic, but not directly because of job loss. There are many people and many types of circumstances into the future that we maybe can't predict, where the economy can be thrown into disruption, or people's lives can be thrown into disruption, and you find yourself living on the streets or living in poverty. So taking that kind of approach, but saying, how can we make it more inclusive and potentially simplify or even replace some of the more complex systems that have been put in place, is something to, I think, do in consultation with provinces and territories and see how can we harmonize this. The reality is that over time, we've been seeing the tremendous role of government in being able to provide those kinds of supports for citizens, and we've cobbled together over time improvements to social services and programs. But at some point, it becomes so overly complex that it becomes difficult for individuals sometimes to even know they qualify for an existing program or service, or the means to get at it, and they don't quite qualify, and it costs a lot to administer that kind of system, and it ends up not actually meeting the needs of many. So I think, yes, in short, what we've learned is that a simplified program that can meet the needs of families and individuals who are affected by all kinds of crises is possible and can work.
A follow-up question to that, Doctor, for my colleagues, myself, and for Canadians watching, are there best practices out there from other countries or other regions of the world that we can extrapolate success? And I know that's a broad definition, but are there best practices out there that are happening right now or that have happened that we can learn from?
Yeah, I think there have been multiple experiments at national or subnational levels that have tried for a time an approach that's a basic income approach of one kind or another. It's difficult to just take examples from another jurisdiction and apply them directly to Canada. You have to look at, obviously, what context are we putting it in? But what many of these experiments have shown is similar to what we've just talked about with CERB, that they do work. We've shown, even in the Canadian experiments that have gone on in the past, in Manitoba in the 1970s, and even more recently in Ontario, although that program was cut short prematurely, unfortunately. But even in that short time, we found that the direct impacts on improvements in health of both the individuals and their children and families was substantial, and that there was actually decrease in utilization of health and social services by families as their lives got more stabilized. And it's also been shown that, overall, the proportion of people who are using those funds in very productive ways to obviously just stabilize their initial crisis, but then find ways to build back and do re-education, invest in their families, has been substantial and transformative for many of these families. So yes, the research has been done. There isn't a need for another pilot project. It's been shown to work. What's needed is now to implement in the context of our Canadian system.
Thank you. Mr. Chair, how much time do I have?
30 seconds.
Just a very quick question, Doctor. From the research that I've been able to extrapolate from different sources, I'm wondering if you could talk a little bit about, and we've talked about it here on in terms of entrepreneurship, but in terms of youth entrepreneurship and how basic income can assist in assisting young people establishing their own businesses.
Yeah, there's a strong case to be made for basic income from multiple sectors, and certainly from the entrepreneur sector, there's some good research that's been done there as well. The ability to know that during that critical development time where there isn't assured income coming in, but there's a need to develop that base and start a new business going, or as we've seen during a pandemic now, where those who were, unfortunately had just launched a new business and then were facing these kinds of crises, the ability to float over. Those are both two sides of the same coin, and there's a real ability to stimulate that kind of creativity and entrepreneurship because of that understanding that you're starting from a stable base.
Thank you, Doctor.
Thank you, Mr. Kellaway. Nous allons maintenant, Monsieur Thériault.
We now move to Mr. Thériault. Mr. Thériault, go ahead, 6 minutes. Thank you. Thank you very much, Mr. Chair. I'd like to thank all of the witnesses for appearing today. I'll speak first to Dr. Bélanger. We're starting a third wave. We had the first, the second, and now we're starting the third. The pandemic forced our networks to put two categories of patient, COVID and non-COVID patients, into place. And we have the impression that the real effects of the pandemic have been forgotten, but that they'll be seen when we see the state of things with non-COVID patients. So it would be incorrect to think we've gotten through the pandemic when everyone is vaccinated, because there will be collateral effects to the pandemic for perhaps more than a year, more than 2 years perhaps. The numbers are striking. You said 110,000 people are waiting. 63,000 have been, or 63% of which are overdue. And you said colon cancer is the third most common and the second deadliest. So what are the effects of those delays? What do you fear? So the biggest impact with colon cancer is when we see patients when they're asymptomatic and we're screening them. And not seeing those patients now and seeing them later, well, there will be a sure, proven increase in the number of colon cancers in the coming months and years. On average, non-pandemic, there are 55,000 stool samples in Quebec with a positivity rate of 2,700. And 35% are in the latency phase. So every month, 1,000 patients are seen for an endoscopy, and colon cancers are prevented. So every month that these patients aren't seen, their lesions progress, and an 8-month delay for a patient doubles the risk of cancer and doubles the risk of an advanced cancer. So not seeing these patients now who have no voice, who have no symptoms, is more than just pushing a problem back. It means we go from a preventable cancer to actual and advanced cancer and deadly cancer. Currently, in your practice, and based on what the association has seen, because we'll have the real effects, we'll see them over the next few years, because someone who's diagnosed with cancer and who has a path that ends in death, well, that's not in a month that will show up. It'll be in a number of years. So in your practice, before the first wave, the network was already facing issues, chronic underfunding. Everyone has told us that. So after the first wave, you said there was catching up to do. Do you think that if we continue as we are, we'll be able to catch up? And if so, in what amount of time? To date, there's been no month where in Quebec we were able to do the same number of colonoscopies as we were supposed to do. With current resources, we're not even able to do the catching up work and to stop that backlog from growing. During the pandemic, we did 63,000 fewer colonoscopies than the previous year. The monthly average of colonoscopies in units in Quebec is 22,000. So that backlog versus last year is a 3-month full-time job for all endoscopy units in Quebec to just deal with that backlog, excluding new patients. So with current resources, we're not able to accommodate those patients who will be coming in. The factors with distancing, sometimes patients can't come to their appointments because they have to isolate, means that monthly productivity of colonoscopies can't be the same with current resources in place. And if we continue on this path, we'll just have an increased backlog, and then we'll be dealing with sicker people. On the ground, you have to talk to a doctor on the ground. Every day, we see disasters. People who are in situations where they have late diagnoses and there are more advanced diseases, hospitalizations, avoidable deaths. And that's what we're seeing every day on the ground. the Association of Radiologists, Dr. Soulez was telling us that those backlogs would increase mortality. So you have the same fears, saying that we need to invest sustainably and increase federal funding, health transfers after the pandemic. Does that make sense to you? Listen, I'm speaking on my own behalf. What we need for colon cancer is to have investments that are dedicated and specific to us, to endoscopy, so we have staff and rooms so that we're able to operate. We need investments. The scope can't be accommodated through reorganization or streamlining, not the scope that we have now. We need financial support, and that will allow us. Gastroenterologists are available to work more. We do have the manpower to do this. We need access to units that are well organized and secure, and we need to be able to pay our staff, those who need to stay with us rather than go elsewhere. Thank you.
Merci, Monsieur.
Thank you, Mr. Tidio.
We'll go now to Mr. Davies. Mr. Davies, please go ahead. 6 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here. I think we all agree on this committee that the opioid death crisis in this country is sobering. Since 2016, we've had over 20,000 Canadians die from overdose deaths. Last year here in BC alone, we had 1,700. That's the deadliest year on record. And the last quarter of opioid deaths is the highest that Canada has ever recorded since we started surveilling numbers. Ms. McBain, to you, what, if any, is the connection between the federal policy of criminalization of drug use and the harms that come from drug use, including deaths?
Criminalization of people who use drugs tends to push them into the corners. It is incredibly stigmatizing. I mean, what is more stigmatizing than being arrested and being thrown into the criminal justice system when in fact you have a disorder, substance use disorder, and you need to have drugs that you can only find on the street in a dangerous and illicit way. If possession of illicit substances was decriminalized and people were able to feel safe, there would be, in normal times, there would be more congregating in communities and so on. But during COVID times, it just exacerbates the idea of using alone. So decriminalization is essential for people to actually come out of the closet, as it were, seek services if they're available, and to start on a path possibly of recovery. So we find that as a very big step in solving this tragic problem.
Thank you. Now, Mum Stop the Harm has called on all levels of government to work together to change current drug policy to an evidence-based approach that, according to your website, says respects and supports the human rights of people who use substances, and specifically to ensure access to a safe supply of pharmaceutical-grade substances in addition to decriminalization. Why is it important to address the supply side of the equation in addition to decriminalizing the possession?
Using the substances that are available to people that are the illicit toxic substances on the market today is the reason, the one single reason that people are dying or suffering permanent brain injury. So it just follows that if a safe supply of pharmaceutical alternatives was available to people and they were able to access it in a low barrier way, they wouldn't die. That's the hope. We know that it won't completely end the problem, but if the federal government and the provinces could work together to remove the barriers to actually implementing a safe supply of opioids, in particular, safe supply of fentanyl, which sounds crazy, but fentanyl and heroin, and it was safely distributed and used, people would not die. I mean, that's our primary goal here, is to keep people alive. And once people are stabilized on a safe supply, the evidence shows that they do their lives stabilize. They're more inclined to seek treatment, and they can even get jobs and hold good jobs if they don't have to do that everyday search and the everyday danger of accessing illicit drugs.
Now, you touched on treatment, and I think all of us in this committee also are aware of the the pressing need for people to get just-in-time treatment when they want to seek help, and of course the fact that we just don't have the public capacity. I think we're aware that the delivery of treatment services in this country is essentially privatized. So I'm just wondering if you have any suggestions for what the federal government could or should do to ensure that Canadians can get access to treatment on demand through our public healthcare system, which I think you pointed out clearly isn't the case right now.
Well, I think it's a matter of funding, funding recovery and treatment facilities, and also having good surveillance, good oversight, good policies in place for those facilities is critical. Substance use disorder is the only health issue in this country wherein people have to go to the street to get their medicine, and the treatment for them is inaccessible, mostly for their families because of the cost, or there are way too few subsidized beds in the facilities. There's a lot of problems that could be solved, that we know how to solve, but it seems to be a matter of political will for one thing, but funding, definitely funding. We don't send people with heart disease or diabetes to unsupervised, without oversight facilities. So we need to treat substance use disorder like any other disorder, any other health condition.
I've got a few seconds left. Prime Minister Trudeau has explicitly ruled out decriminalization of drugs. He says that it isn't a silver bullet. Do you accept that logic? And if not, why not?
I absolutely do not accept that logic. And I would say that we need, about 6 silver bullets. It is not a silver bullet. It is one step towards treating people with substance use disorder as human beings with everything that we all have. To shut it off like that, to me, is unconscionable. And I wish very much that he would reconsider that statement.
Thank you.
Thank you, Mr. Davies. That brings us to our rounds of questions to a close. We'll have to thank the witnesses at this point so we can bring in our next panel. So thank you all for your time today and your preparation and for sharing with us your knowledge and your experience. And with that, we are now suspended. resumed. So we are resuming meeting number 30 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic. So I'd like to welcome the witnesses for this panel. As an individual, we have Amadeo Danguili, professor, Carleton University. With the Association des médecins hématologues et oncologues du Québec, Monsieur Dr. Martin Champagne, president and hemato-oncologist. For chats, community and home assistance to seniors, we have Christina Bizance, chief executive officer. And with Don't Forget Students, we have Brandon Rael Amiot, co-organizer. Thank you all for being here, and we will start our by inviting witnesses to make statements. So, Mr. Danguili, please go ahead. 6 minutes, please.
Thank you for inviting me, Mr. Chair. I just want to contribute a study. I assume that you guys are hearing me and everything is a developmental study on the effects of COVID and children and on children and families. It is a study that we have been doing for, it's an ongoing study of a research synthesis. So we basically have collected all the available peer-reviewed, high-quality research. And today I want to just give you a snapshot, a summary of some of the progress that we have been doing on the results. The impact of COVID can be actually categorized in three broad categories: family dynamics and stress in parents, children's mental health, nutrition, physical activity, and media. And simply to give you an idea, now these are categories that are a little bit artificial. They overlap sometimes, but the important thing is that capture the main essential ingredients of what is the impact. Regarding the stress on parents, one of the things that we see reported in the peer review literature is the effect of homeschooling and the fact that parents have to juggle careers and have to take cuts or financial decisions to lessen their income to stay with children. And there aren't a lot of external support to actually make up for these losses. But at the same time, the surprising thing is that there are protective factors and positive influences on family dynamics due to the fact that children are closer to parents. Now, one of the essential things that has been very much talked about is what is called now the she recession, the fact that women are hardly hit by this economical collateral damage of COVID. And one of the things that is surprising is that there is a perception that men have actually taken up more of the family domestic work. Even so, the women continue to be kind of in a disadvantage because they are likely to have jobs that cannot be performed at home. They work 15 more hours at home on unpaid domestic labor, and they are the ones that are actually suffering more for the economical situation, with an increased risk of gender gap, increased poverty, and actually the amount of divorces. And you should look at the Stats Canada report that was released in 2020. For young and middle and adolescent children, we have an array of factors that play. Disability is one major factor, which also plays into this distress and the family's hardship. Domestic violence that is not necessarily addressed by the fact that there is isolation and home orders. Lack of socialization, especially hitting young children in periods in which socialization is very important for communication and learning. Virtual learning is also, for part of the students, is not a positive experience, and it's not necessarily leading to very good outcomes. You have poverty in youth, and there are also the added effects of media exposure. Especially the fact that we constantly are immersed in a sort of media kind of war disaster climate that unconsciously plays on mental health of young children. Many of these changes are due to school closure or the flip-flop of closure and opening and changes. And the main outcomes are documented as being increased anxiety and depression. To conclude, other aspects that are intimately correlated and have an effect on children and youth are the sedentary and decrease of physical activity that is correlated with a higher use of media, social media and mobile devices, and correlate with a decrease in the quality of nutrition, especially take-home, fast food and other things that are not really appropriate nutrition for development. We are also working on a general framework to make more sense of this. I have provided the document with which you could look at the framework that we are creating to actually interpret and organize this data and make it more accessible and contribute to the ongoing study. Thank you so much.
Muted, Ron.
Sorry.
Ron, you're on mute.
Thank you. It's probably just as well. I was trying to pronounce this name in French, and I was utterly failing, so I apologize. So we'll go now to Dr. Champagne, President and hemato-oncologist. Ms. Doctor, please go ahead, 6 minutes.
Bonjour, Mr. Chairman.
Good afternoon, Mr. Chair, members of the committee. Thank you for your invitation. I'm going to speak to you about the impacts of COVID on cancer. Cancer is a chronic disease with acute episodes of continuous care over a long period of time. It is very different from single episodes of care, such as orthopedic hip or knee surgery or surgery from cataracts. So the ramping down of medical activities has resulted in diagnostic delays that have major impacts because during these delays, the cancer has progressed with an increased risk of recurrence and a decreased chance of cure. So the consequences for patients are significant because there will be increased morbidity, i.e., more people being sicker and sicker for longer. So they'll need an increased intensity of the treatments required, and they'll have increased mortality because they're at a more advanced stage. So when we diagnose cancers too late, the impact of the pandemic will be felt for many years, both on patients and on the human and financial resources of the healthcare system. I would like to draw your attention today to 3 elements: wait lists, patients who have waited longer than recommended on these lists, and diagnostic delays, which are very revealing about the real impact of the pandemic. First, screening programs. Patients who have symptomatic issues go to ERs, have been seen, and most of them have been treated. So that hasn't changed too much. But screening programs allow diagnosis at earlier stages of the disease, those who don't have symptoms, and we estimate that there's a reduction in mortality by 20 to more than 40% because they're asymptomatic. In addition to finding diseases at earlier stages, they need much less intensive treatment. So it may be just a surgery rather than surgery and chemotherapy, for example. In Quebec, for example, colon and breast cancer screening programs were halted during the first wave of the epidemic in March 2020. To date, it has not been possible to catch up on that diagnostic backlog, and I'll show you data in a few moments. Dr. Bélanger talked to you in the first panel, and so she talked about the fecal blood screening strategy for colon cancer. Patients who test positive undergo a colonoscopy. So polyps are found, precancerous lesions, or even cancers. So currently, we have a significant reduction of about 28% in Quebec in tests compared to the previous year. And that cumulative backlog, even though there were calmer periods during the summer, that backlog has not been cleared. So what we know is the less we screen, the less we diagnose. There are not fewer cancers, it's just that we haven't detected them. So if you look, patients who have waited for too long, so there are fewer stool samples being done. And when we do want to offer colonoscopies to people, there are fewer of those, and there are significant numbers. About 152% of our outstanding referrals. So in total, currently, there are about 800 fewer colon cancer surgeries this year in Quebec compared to the same period in the previous year. Dr. Bélanger highlighted the fact that it was the third deadliest cancer in Canada. So this has a very significant impact. When cancer progresses, surgery can become obsolete, and then you have to use chemotherapy or radiotherapy. And then for breast cancer, screening programs are 30% lower, so we're only at 70% compared to the previous year. Fewer patients are being diagnosed at early stages. And for all of Quebec, currently, there's a reduction of about 22% in the number of biopsies confirming cancer. So that's the first step, a biopsy. So for those 60,000 new diagnoses, there's a deficit of about 10,000 diagnoses. So there's a significant backlog. In conclusion, we really need to be concerned about these delays. We'll be paying a price as patients, as a society. When there's a 4-week delay in a diagnosis, the risk of mortality goes up 6 to 8% in 13 of 17 cancers studied. For colon cancer, it's an increase of about 6%, and breast cancer, it's about 8% for each 4-week delay in diagnosis. So British epidemiologists therefore estimate that the increase in mortality for cancer patients could be as high as 20% for the next year, and that the price to pay could be over the next 10 years, with an excess 10% mortality over the next 10 years, every year. So how do we catch up? We need significant investments in human and material resources. That way we can offer therapy to patients. And I've added a number of annexes from the Health Ministry that will give you examples of diagnostic backlogs for different tests that I've mentioned. That concludes my presentation.
Merci, Doctor. We go now to CHATS Community and Home Assistance to Seniors. Ms. Bizance, go ahead, please. 6 minutes.
Thank you very much, Mr. Chairman and members of the Standing Committee on Health. My name is Christina Bizance, CEO of CHATS Community and Home Assistance to Seniors. As an advocate for providing choice for seniors to age at home, CHATS appreciates this opportunity to provide input on the effect of the pandemic on older adults. CHATS is the largest senior serving organization in York Region and South Simcoe, supporting 8,500 older adults each year through a variety of multicultural programs and services designed to support the health, wellness, and independence of seniors and their family caregivers. Our person-centered programs focus on the social determinants of health in order to enable our clients to live safely and with dignity at home, keeping them out of hospital and long-term care as long as possible. CHATS has been deemed an essential service provider throughout the pandemic, providing support such as transportation to medical appointments, Meals on Wheels and food security services, caregiver counseling, and telephone reassurance calls, just to name a few. Our personal support workers continue to work on the front line within our assisted living sites, helping seniors with bathing and personal care, meal preparation, medication reminders, and other activities of daily living. We've kept our adult day programs open for high needs and dementia clients, which in turn provides their caregivers with greatly needed respite. And when we're no longer able to offer in-person community wellness programs due to public health restrictions, we very quickly designed and delivered virtual wellness and social programs to ensure that our seniors were able to stay connected and engaged with the programs and each other. In addition, we've worked with our hospital partners to support hospital-to-home transitions for seniors, reducing their risk of readmission. We're very thankful for the funding that we received from the Seniors New Horizons program and other supports, which made it possible for us to be innovative and serve our clients in a virtual world and address emergency needs for food security. While the ongoing pandemic has illustrated that being in their home and in their community is a safe place for vulnerable seniors to live and receive care, it has also exposed a number of growing risks. I'd like to highlight 4 of these. First, the imposed social and physical isolation has led to increased loneliness, depression, and a general decline in physical and mental health of seniors. Many of our clients have not had physical contact with family and friends in a year. Concern with their personal safety and allowing workers into their homes caused a number of our clients to reduce or cancel services, further insulating their social isolation and putting their safety and well-being at risk. Second has been the impact on family caregivers who have been experiencing unprecedented, overwhelming levels of stress in keeping their loved ones at home. Frustration and anxiety have led to increased potential for and incidence of elder and caregiver abuse. The lack of sufficient respite care and support is leading many caregivers to their breaking point. Third, the pandemic has shown just how dependent we are on the scarce resources of personal support workers in all parts of the health system. The overall shortage of PSWs in Ontario is even more prevalent and more critical in the community sector. Our frontline heroes are also experiencing high levels of stress and anxiety for fear of being exposed to COVID or exposing their clients to risk. Many come from racialized and marginalized communities. With wages generally lower than in the long-term care and hospital settings, the community sector is not in a position to compete for a resource that is crucial to enabling many frail seniors to continue to live at home where they want to be. And lastly, when the pandemic was first declared, an incredible spotlight of concern shone upon seniors. New funding, community response, offers of support to make phone calls, send letters, and other examples of generosity and caring were unprecedented. But as the pandemic continued, the interest started to wane. Funding support ended with the fiscal year, but the needs and challenges for seniors because of COVID hasn't stopped. Let's not leave our seniors behind. I thank you for your time and attention and look forward to your questions.
Thank you, Ms. Bizance. We'll go now to Don't Forget Students, Brandon Amiot, co-organizer. Mr. Amiot, please go ahead, 6 minutes.
Anin Kinewea. Hello, everyone. My name is Brandon Rael Amiot. I'm a student at Lakehead University in Orillia and a co-organizer with the Don't Forget Students campaign. I'm speaking to you today from the territory of the Chippewa Tri-Council of Rama, Beausoleil, and Georgina. These are lands under the Williams Treaty and Dish with One Spoon Wampum, long stewarded by the Anishinaabe, the Haudenosaunee, and the Wendat. I mention this not just because it's important to recognize the land, but because of the impact that the pandemic has had on Indigenous peoples, and in particular, Indigenous students and students of diverse communities. Members, I speak to you today to raise grave concern about the impact of the pandemic on post-secondary education, students, and recent graduates. This pandemic has taken an immeasurable toll on our financial outlook, job prospects, our quality of education, and most importantly, our mental health and community health. In the past year, students and recent graduates have fought hard to get governments to listen and to act. At the beginning of the pandemic, we called for the CERB to be extended to students and recent graduates. And after almost 2 months of advocacy, the Canada Emergency Student Benefit was launched. This provided 4 months of relative stability and support for students and recent graduates, but over hundreds of thousands of international students and recent graduates were not eligible, and recent graduates who are still in search of jobs who were not eligible for CERB could also not access this program. The other large program, the Canada Student Service Grant, as you all know, did not end up rolling out, and it also did not equitably address the impact of the pandemic on students. In the end, and to date, the over $9 billion that were originally promised to aid students through this pandemic, only 3.2 billion remains unspent. If I'm to be frank, I feel that politics came before students and before responding to the impact this pandemic had on us, the post-secondary system, and our communities. We're now 13 months into this pandemic, and I probably don't need to tell you that here in Ontario, where I live and go to university, new COVID-19 cases have hit an all-time high, and this third wave is particularly impacting me and other young people across the province and across the country. The toll this has had on my mental health is difficult to measure, and it's difficult to measure the impact it's had on all of our mental health as post-secondary students. But research from the Ontario Confederation of University Faculty Associations just this past November and others paints a bleak picture, one that I'm living in. The lack of attention to post-secondary from all levels of government during the pandemic and a legacy of systemic underfunding has led to the pandemic being able to wreak havoc not only on our education, but on our lives. One of the casualties most recently was Laurentian University. This is the product of mismanagement and systemic policy failures and underfunding. And that's not only billions of dollars lost in economic activity, but a community ripped apart. These systemic issues are not unique to one school. They are present in this system across the country. Students and recent graduates were barely making ends meet as it was, and we were barely making ends meet now. And despite the picture that is sometimes painted, we are not a homogenous group of recently graduated high schoolers. Students are parents, caretakers, workers. Some of us, myself included, are disabled and are struggling to cope. This is not an environment conducive to learning. It is not an environment conducive to innovation. Meanwhile, recent graduates and those about to graduate are facing one of the worst job markets in a generation and will be crushed under the weight of record high student debt and unreasonable payments. What possible justification is there for collecting student debt payments and interest during a pandemic? In the best of times, these payments are difficult to make. We have to find a better way, not just to get us through the COVID-19 pandemic, but to fully realize the potential of post-secondary education in this country as a part of a social, environmental, and economic recovery. In the short term, all funds that were originally allocated to students and additional funds need to be invested towards supporting us through the pandemic. This means relaunching the Canada Emergency Student Benefit, or whatever you want to call it, in May, and including international students in eligibility. It means including all soon-to-be graduating and recently graduated students in direct supports. And it means extending the moratorium on student loan debt and interest payments until at least the end of the pandemic, with commitments to significant student debt relief. But we have to think about the long term, and that means systemic investments in post-secondary students and education. This means expanding the Canada Student Service Grant with the goal of returning to a 50-50 cost-sharing model. This means increasing funding to institutions, and it means creating a federal vision for a universal post-secondary system in collaboration with students, workers, and academics. With these measures, the government can begin to address the impact of the pandemic that has had on students and our mental health and our well-being, and the long-standing inequities and gaps within the post-secondary system. In closing, I want to thank this committee for reaching out to hear from students, and I urge members to take action. Miigwech, thank you.
Thank you, Mr. Amiot. And thank you to all the witnesses for your statements. We will start our round of questions at this point. We'll start with Mr. McGuire. Mr. McGuire, please go ahead. 6 minutes, please.
Yes, thank you, Mr. Chair, as well. I want to first go to Mr. Denguilia and Doctor, and just to look at the best ways. You've talked about the delay in medical screenings, and and interventions. There's delays in all ages, I believe you said. And so can you just give us your impression of what is the how this compares, I guess, to other countries? I guess is one of the biggest issues that I'd just like to know. The delay in medical screenings, they say there's help for teachers and that sort of thing in those areas in your presentation that you gave us today. Can you just elaborate on how that compares in Canada with other countries and what contexts they have for reopening?
Well, I can tell you that Canada is doing much better than countries like Italy, and this I can tell you even from my own experience. I guess one of the things that Canada is doing very well is managing the online better than other countries, but we are. I would say, I mean, better and worse. It's a relative terms, just to be clear. We are lagging behind some of the Scandinavian countries instead, and other countries like Australia and New Zealand. The approach that most of the countries in EU, for example, are taking is to enhance the online environment, to give schools and parents more contact, and to change the way that schools operate with the input of the students and the parents. What they have done instead in Scandinavian countries is to actually reduce class sizes, to have more one-to-one time, to redefine spaces for physical activity and other things, which is critical right now because play and socialization, for example, in the young children, it's vital to have. You cannot replace it with the online. My 30-year-old, on a computer sits like a zombie. It doesn't really engage with the media. You need some form of engagement that is person to person. We can do it. I mean, as a country, we have the ability, we have the skills, that we have some of the best schools in the world, but we still not quite getting it. Now, compared to other countries that don't have resources, of course, we are doing much, much better.
Yeah, thank you. You were talking about the homeschooling and the working at home, the interference or the change is a lot for many parents. The disabilities and the domestic violence. Can you just elaborate a little bit on that and what needs to be done?
Well,
on the particular, say talk about the disabilities as a specific case.
Well, disability is, I think, we need to have much more one-to-one and tutoring, and we need to have a lot of support for parents. I mean, parents are really struggling, and so I think we need to find ways to do that, to have parents have a way to also create a space of distress for parents that maybe are stuck in an apartment with children, and one of the children or more have challenges and need to be helped.
Yes. Thank you.
Okay.
I hope I get your name right. Ms. Zanz, is it? Christina?
Yes, that's correct.
I just want to first of all say thank you for all of the work that you're doing in frontline efforts. You just can't say enough about the frontline workers and the caregivers that have made the situation so much better than it could have been. And I'd just like to ask you a little bit about, you talked about the social isolation and that sort of thing as well. And I've heard some really devastating stories in meetings that I've taken from senior advocates regarding the feelings of social isolation, as we just talked about, that many are experiencing during this pandemic. And so being cognizant of those, of the federal and provincial jurisdictions that we have to deal with, is there anything that we as the federal legislators can be pushing for to combat this issue? What can we best help with?
Well, and thank you very much for that question. And I appreciate that currently we are sort of predominantly funded by the provincial government and bound by the rules and regulations of the province. But I think that looking at the challenges of social isolation isn't something that's unique to COVID and the pandemic. This has been going on for a long time. And I know that the federal government has had discussions around the development of a federal senior strategy, as well as potentially looking at national long-term care regulations and a structure. And I think within that context, we also need to be very, very realistic of addressing social isolation and loneliness on a pan-Canadian basis, and some of the ways in which the federal government can support the provinces and then down to the actual frontline agencies to address those challenges and concerns. And part of that is looking at ways in which we can reimagine housing structures and opportunities. Instead of rushing to build more long-term care facilities, for example, of 300 and more beds in towering facilities, can we not look at how we can address the housing strategies and working with Canada Mortgage and Housing to incentivize developers to start building different forms of product that enable seniors to be able to age in place and do so in a way that promotes social engagement amongst them.
Yeah, I think that's a good point. I mean, a lot of our seniors facilities are over 60 years old. So
thank you, Mr. McGuire. We'll go now to Mr. Kellaway. Sorry, Mr. Van Bynen. Mr. Van Bynen, please go ahead. 6 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses who have taken the time to share their perspectives and to help inform this committee on the collateral impact of COVID. My question is for Ms. Bezans. Hi, Christina. It's always good to hear from you, and thank you for being here today and for the work that you do to support seniors and caregivers in York Region and in Simcoe County. I've seen the positive impact of your important work over almost 10 years that we work together in the Newmarket Council. And I appreciate your hard work in recruiting and engaging so many volunteers and your efforts to raise critical funding that you need to serve your community, like so many other nonprofits. You support a broad and diverse community. And firstly, I'd appreciate hearing on how the COVID-19 has impacted the way you serve your clients and how you've adapted to continue your support.
Thank you very much, MP Van Bynen. Well, I think that the key change or impact that has occurred on our services has been the need to move to virtual programming as opposed to in-person programming. And not unlike many other home and community support agencies, we pivoted very quickly to look at ways in which we could deliver social connectivity, but using virtual means. By that, I'm referring to both telephone as well as internet communication and programming. We also developed a number of activity packages that we developed through our adult day programs and dropped off in a contactless way to many of our clients so that they had activities that would engage them in things like crossword puzzles, recipes, things that they really could use to make them feel connected, even though they were required to be physically isolated and sheltering at home. But I think the biggest thing is that shift to virtual programming that we don't anticipate is going to go away anytime soon. And even when whatever the date is that the pandemic is declared over, we know that our clients are going to continue to have hesitancy and fear about going out and being in larger groups again. So we anticipate that the need to continue to provide virtual programs and support our clients to do so through providing them with tablets and providing them with internet connectivity, providing them with technical support is going to become even more important because that's not something that typically a lot of older adults would have had access to or be comfortable using. And I can report that the response to our virtual programs has been overwhelming. I mean, it still doesn't replace the in-person contact, but it has been very, very well received because it is a lifeline that people are able to know that they can connect on a daily basis or a couple of times a week, can access physical activity through, we do yoga and other physical activity exercises for them so that they know they've got that to look forward in that connection.
Thank you. Now, how many volunteers do you have to deliver the service?
Well, before COVID, we had close to 500 volunteers, and they truly are the heart and soul of the organization because we wouldn't be able to deliver near the breadth of the services that we do without them. Unfortunately, and particularly in the first wave of COVID, you'll recall that anyone over the age of 70 was advised to shelter at home and not go out. Our clients tend to skew to retired people in that age group. So unfortunately, we had to ask a number of our volunteers just to hold off until it was safe for them to be able to become involved again.
Thank you. Now, the Standards Council of Canada, the Health Standards Organization, and the CSA Group announced the launch of their process to create a new national long-term care standards. The new national standards will take into account lessons learned from COVID-19. We've heard a lot of that from you already. But based on your extensive experience in working with seniors, what would you recommend would be important considerations for this group to explore?
So let me say this, if I may. You know, I think the time has come and the experience from COVID and the tragic situation that affected so many frail elderly in long-term care homes has really highlighted, certainly for our organization, that it's time for us to stop questioning why people need to go into long-term care and instead focusing on how can we help them to stay at home in their own homes where they want to be. And, you know, without doubt, there is a need for long-term care for, you know, very complex needs and conditions. But we also believe that with better investment in home and community supports, that it is quite possible and quite feasible and better for people to be able to age in place and to have the choice to do so instead of solely investing in the creation of more institutionalized care. We need to start talking about how we enable people to be able to exercise their choice to stay at home as long as possible.
Now, if the federal government leads to a process to set out long-term care standards, how might those standards help to strengthen the home and the community sector?
I think it needs to be seen as an and situation. So long-term care, but long-term care needs to include consideration of home and community supports as well. So it's not an either or option, but an and. And I think that looking at those standards and looking at a way in which there could be better integration between long-term care and home and community supports. And by that, I mean not just assuming by default that when somebody ages and has complex care needs or advanced dementia, that long-term care facilities are the default, but looking at how there could potentially be a way to support through both sectors those individuals who need the enhanced care, but can still be involved and connected to their communities.
Thank you, Mr. Van Bynen. C'est Monsieur Thériault.
Mr. Thériault now. Mr. Thériault, go ahead. 6 minutes. Thank you very much, Mr. Chair. I'd like to thank all of the witnesses for appearing today, for providing their insightful testimony that will surely help us make important recommendations. Dr. Champagne. First of all, thank you for your presentation, which was very clear. Clear enough to scare us, really. Because what you've said is that over the next 10 years, there's a higher mortality risk of 10% potentially. You can't do medicine without diagnoses. And with cancer, the diagnosis needs to be on time. And so screening is crucial in fighting cancer. Currently, non-COVID patients are paying the price of this pandemic, just as COVID patients are. But it's not discussed very much, not enough. If we want to find solutions, we need a diagnosis, a clear picture of reality. So following your testimony, we see that the pandemic will have two impacts in terms of costs. There will be greater costs on an ad hoc basis to fight the pandemic, but there's also an increase in costs for the system because of these delays and because of the offloading. So this underfunding was present before the first wave, and now we're at the third wave. Nothing indicates that there couldn't be a fourth wave. Are you concerned, and what needs to be done? Very concerned. If we looked at colon cancer, if we come back to that example, if you have a stage 1 disease, which is very localized, just a surgery can put an end to it. You have an 80% chance of healing, and then it's done. But if the disease has spread to around the tumor, then you're in stage 3, and then you need chemotherapy during about 6 months. So there are costs to that, and there's morbidity, higher morbidity, because they have the impacts of treatment, and your odds of being cured are lower, around 50 to 60%. So a third of patients will have a recurrence, and then they'll be back in the healthcare system for more therapies that cost money and take up human resources. Physical resources exist. Hospitals exist. We can always revamp hospitals. But anti-cancer treatments cost tens of thousands of dollars per episode of care for a patient. So these are costs that are going to be recurrent for the healthcare system for a number of years, given that recurrences don't necessarily show up in the first few months after the initial diagnosis. It could be 2, 3, 5, 10 years later. So that's what will be a big burden. At the human level, patients will suffer more, and also for the whole healthcare system, which will need major human resource and material investments. So Dr. Bélanger was talking about colonoscopies that cost $1,000. So instead of that, we'll have a patient who will become a chronic patient and have multiple interactions with the healthcare system, and it'll spread out over a number of years. So what you're saying is that will have a cost for their quality of life, and also a cost in terms of different treatments, and it'll be more expensive for the system. So we should expect an increase in cost to the system now if we want to treat these people. But we're not able to do so with the resources we have now to treat those people. Resources are already very limited. They're stretched. And during that calmer period before the second wave, between the second wave and the beginning of the third wave, we weren't able to get back to 100% to that same capacity as before the pandemic. So we still have that backlog. Quebec and the provinces have said that the chronic underfunding of health is related to the fact that over the past 30 years, the federal government hasn't done its part in the area of healthcare transfers. Quebec and the provinces are asking for an increase of from 22 to 35 cents on the dollar. So that's $28 billion. And they want it to be indexed at 6% because now we're at 3%. The Prime Minister often said that this would be dealt with after the pandemic. We're in the third wave now. Do you think we can say there's a before and after, and that the healthcare system should already be invested in so we can treat people? I'm in medicine, not in politics, but we can imagine that currently the healthcare system won't survive this financial burden imposed by the COVID pandemic without major additional investments. And that would mean, have you looked at the costs between $1,000 for a colonoscopy and a colon cancer case that needs surgery, chemotherapy? How much would that cost? Each episode of care over the course of a few years, and if we have more advanced cases, it's tens of thousands of dollars per year. Lung cancer with immunotherapy costs many thousands of dollars, so it's very significant for the healthcare system. That's for an advanced lung cancer case. Do you have the impression that with the organization of appointments, with appointment making, the system is a little outdated? There's often faxes. Would there be a need for investment, as the Canadian Association of Radiologists requested, so we can have a much more efficient system for appointment making? For the cloud, for example, so that people can make an appointment themselves. These are things that could really facilitate access to care. COVID imposes physical distancing. A lot of hospitals are outdated. So when you have a waiting room for an ultrasound room and for MRIs, we can't do like we did before and have 15 patients come in at the same time and put patients close to each other in waiting rooms. So there's that physical and time distancing. If somebody needs a scan, somebody else can't be in the room at the same time. So that decreases the system's capacity. So yes, we need better communication for diagnosis, and we have a lot more telemedicine now. There's a lot of things that have been put in place during the crisis, but there's a lot of things that haven't become digital. So there's a lot of things that could improve. Thank you. Thank you, Mr. Tidio.
To Mr. Davies. Mr. Davies, please go ahead, 6 minutes.
Thank you, Mr. Chair, and thank you to all of the witnesses for being here. I'm going to direct my questions to, don't forget, students, if I may. May I call you Brandon?
Yes, absolutely.
Thank you, Brandon. I guess I want to zero on a few things. I want to preface by saying I know every single Canadian has been terribly affected by the COVID crisis. But I think that seniors and young people have been particularly had their lives disrupted in certain ways, and I think students in particular in that regard. So I want to ask you a couple of specific questions. What would be your recommendation to the federal government in terms of the appropriate policy to handle student debt and interest payments for student loans at the federal level?
Thank you for the question. I think, as I said, short term, obviously, we need to get through this pandemic. We shouldn't be charging students, or rather recent graduates, interest and student debt payments. We paused it for the first 6 months of the pandemic, so I believe the federal government should work with the provinces and territories to refreeze payments to the National Student Loan Service Center for the remainder of the pandemic. Long term, we should be looking at progressively and aggressively writing off student debt federally, the federal portion, and urging the provinces to do the same. Because at this point, we have reached a critical juncture in post-secondary policy and in terms of student debt. It is not in the economic interests of Canada to continue to burden people with student debt. And for particularly if we're talking about the marginalized communities in Canada, low-income students, Indigenous students, women have a longer and harder time paying off student debt than their other peers. So if we're looking at this through an equity lens too, we need to acknowledge that. And so what we should be doing is working towards the progressive elimination of student debt, but short-term student loan interest payments and debt payments.
So just so I'm clear, Brandon, right now, are graduates paying federal interest on their student debts as we speak?
It's my understanding that a freeze on interest has been implemented or is about to be implemented, but they are still making payments. They're still making hundreds of dollars in payments a month. It's just no interest. Frankly, that the removal of interest is not sufficient enough, not during the pandemic and not in the best of times.
So let me sort of flip to the other side of the equation. I think many of us who've been to university know how critical that 4-month, often it's 4-month period to earn money in the summer is to make the money that you need for tuition and to pay your living expenses through the year. So, and I also know that there's been a significant expansion by the federal government in terms of funding of Canada Summer Jobs Program. But I'm curious, what is the situation right now with employment for young people? I mean, we're in the middle of a serious third wave across this country. Are there plentiful jobs out there for students this summer so that they can go out and earn the money that they need to pay their tuition and living expenses come September?
So while jobs for young people are not at the high that they were in May of 2020, the job market for young people still has not rebounded. And while I acknowledge the changes or expansions to the Canada Summer Jobs Program, a summer jobs program is kind of one part of a larger policy we need to implement. And frankly, I've both been responsible for administering a Canada Summer Job as a nonprofit, and I've also been on the receiving end of a Canada Summer Job. There are inequities that exist within it. International students are not eligible. If you're over the age of 30 and you're a student, you're not eligible. So we need to be creating larger programs that capture more students and young people to ensure that people are not slipping through the cracks. And especially with the way the job market is and the financial realities of COVID, that has a significant impact on mental health and well-being. So I think that's part of why I'm calling for the reinstitution of the CESB.
Well, and maybe if you could, I don't know if this is possible, but if you could give us a bit of a glimpse into the mental health of students right now. They've been particularly dislocated. People can't go to class. They're learning online. They're isolated. Can you give us a general idea of how students are feeling in this country right now, and whether there's particular specific challenges facing them that we should know about to respond with policy?
Of course, I mean, it's difficult to capture in a short answer, but what I can say from my own experience is that as much as the university and the student union and other organizations and friend groups have tried to maintain a sense of community, it is not the same. And I mean, that's the case across Canada, not just for students. But the whole point of being on campus is to build a sense of community, student life. That aids in our education. It aids in our coming out of these institutions. It aids in getting jobs, finding community, volunteering. So we've lost a lot of that. And in terms of the impact it has on mental health, I mean, Some students are, have been working at grocery stores, if you're a healthcare student, you've probably been on the front lines in subcapacity. And so looking at the intersections, students are struggling with mental health across the board, but some students in particular are more challenged by the pandemic. I don't have access to my cultural ceremonies as much as I did before the pandemic. And that's, of course, in an effort to keep my elders safe, but it's not the same over Zoom. You can't exactly.
That may be particularly ironic.
Yeah, I think we lost Mr. Amiot. Mr. Davies, go ahead with one more question if you can. I'll give you a little extra time.
Thanks. I'll try to be quick. It's budget day today, Brandon. It's an important day, I guess. What would you like the Prime Minister and the Finance Minister of this country to do for students if you could give them any single piece of advice? Improve internet connections. That might be.
Yeah, I think we've lost Brandon here. Is there
Thanks,
someone
Mr.
else?
Chair.
Like...
Okay. No, I think I was pretty much near the end of my question time anyway. Thank you, Mr. Chair.
Okay, very well. That brings us to the end of our first round of questions. We might be able to shoehorn a quick snap around. Would everybody be interested in 1 minute per party? Okay. Seeing no dissent, I will go ahead with, I believe it would be Mr. D'Entremont. Mr. D'Entremont, please go ahead, 1 minute.
Thank you. I had a great question for Brandon, but unfortunately he's not here. Maybe a question for Mr. Denguili would be just, my wife is a teacher. They've gone through a lot of instances where classes had to be shut down. Classes were not in today. There was 2 instances where schools had to be shut down in the Halifax region. When do you think, will we see truly negative effects for our children as we start to recover from this pandemic? Because I see, there'll always be a sort of a level of an anxiety now as we talk about pandemics or the effects of certain sicknesses as it rolls around.
I think it will be different for different group ages. I think we probably will see the largest impact on the younger kids that start kindergarten and the first grades. And then I think probably, so I would guess if everything goes well this fall, things will really get hot this fall at the beginning of the and so I think the first 3 months of school will be hard, tough for everybody.
Thank you, Mr. D'Entremont. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead. 1 minute.
Thank you, Mr. Chair. Clearly, the provinces are the main player here, but how can the federal government help? This is for Christina Bazans. For example, one of the issues facing long-term care is the workforce. And while nurses are a key component, personal support workers make up the largest part of the LTC workforce. How can we address issues like recruitment, retention of staff, low wages, lack of benefits, insufficient training, and inadequate infection prevention?
Thank you. That's a whole chapter to answer, but a great question. I think that the biggest challenge that we have right now is that there is just a very scarce resource of people who are even interested in becoming PSWs because the wages are low, particularly so in the community sector, and that's a function of how we are funded. So as I said in my remarks, it's very difficult to compete with hospital and long-term care. And with the emphasis, certainly in Ontario, with increasing staffing and increasing hours of care and long-term care, we can already hear the siphoning of PSWs out of community care and community support. So that's very, very concerning. So I think that from a federal perspective, we need to take a health human resource approach that also considers in immigration, making personal support workers one of the priority groups for immigration, and then providing them with the appropriate support adequate wages and working conditions that will retain them in those positions.
Thank you, Mr. Van Bynen. We go back to Monsieur Thériault, s'il vous plaît, une minute.
Mr. Thériault, 1 minute, please. Thank you, Mr. Chair. Dr. Champagne, thank you for having taken the time to draw us a picture of the situation. It's very informative. A quick question now. Since the first wave, have you or your colleagues seen or noticed patients who've had cancers that were less treatable because of that ramping down? We see that every week. Patients who come in with more advanced cancers than if they'd been diagnosed when their symptoms were beginning, if they'd been through a screening program. Unfortunately, this is what oncologists see on a daily basis, not only in Quebec. Some provinces were less affected than ours during the first and second wave, but you read the newspaper and you see that the same scenario is happening throughout Canada. So the situation is dire, and what we've seen in Ontario means that the impacts will be catastrophic for the patients. Absolutely. Thank you. Thank you, Mr. Thériault.
So we'll go back to Mr. Davies. Mr. Davies, I see that Mr. Amiot is back. Perhaps I'll give you your minute, but maybe a little bit extra time to because you lost your witness earlier. So go ahead, please.
Thank you, Mr. Chair. That's generous of you. Brandon, my last question too, I want to give you a chance to answer budget day today. What advice would you give the Prime Minister and the Minister of Finance for what would be the best measures to help students in this country?
Thank you for that, and I apologize for my cutoff. I was actually about to touch on the fact that internet has been an issue for post-secondary students across the country. Even in bigger cities, it's an issue. I have missed many a class because my internet cuts out as it just did there. So I'm now on mobile data. To answer your question, the federal budget today, I say we need to go bold with our post-secondary policy and funding. Of course, during the pandemic, we need to re-implement the Canada Emergency Student Benefit. We need to extend it to international students, and we need to put a moratorium on student loan debt repayment and interest. But long-term, we need to increase provincial or federal transfers to the provinces for post-secondary grants for students to reduce the amount of debt we have to take on. We need to increase institutional funding, and I think the federal government should create a federal post-secondary education committee. We are the only G7 nation with no federal oversight on post-secondary education. I think it's time to get bold when it comes to post-secondary policy so that we can really have Canada stand out on the world stage.
Thank you, Mr. Davies. And thank you to all the witnesses for your excellent testimony. It's most helpful to us in our study. Thank you to all the members for your excellent questions. Those also are most helpful to us in our studies. And I believe that concludes our business for this morning. So thank you all. And with that, we are adjourned. Thank you.